Hello, everybody. My name is Viprakasit. I'm from the University of North Carolina, Chapel Hill. My discussant doesn't need an introduction, but it's Dr. Stephen Nakada, professor and chair at the University of Wisconsin and the American Urologic Association president. And today we'll be speaking about some of the key takeaways from the endourology and stone sections. So there was a very robust discussion within the endourology program this year. It encompassed over 10 plenary presentations, 8 instructional courses, 1 hands-on skill course, 3 symposiums, and specialty society meetings. Amongst the different programs, there were 32 podium abstracts, 187 poster abstracts, and 12 video abstracts. And definitely very challenging to go through all of the presentations to speak about what to highlight today, because they were all very excellent. So when we look back at the key takeaway to bring that you should bring back to your practice, I think it would be no surprise that this year is all about vacuum aspiration. There were approximately 30 abstracts presented on the subject, and granted, the majority were in regards to retrograde intrarenal surgeries or ureteroscopy. There were some additionally on mini-PERC, but most of what we will discuss today will be about ureteroscopy. There were 2 plenary sessions and then 2 symposium debates on the topic. As many of you guys are familiar with, when we talk about vacuum aspiration, we're largely speaking about either fans, so flexible, navigable ureteral access sheaths, so a flexible tip access sheath that you could advance past the ureteropelvic junction into the calyces of interest to suction aspirate stones, or the CVAC 2.0 system, which is an integrated scope, approximately 11, almost 12 French in size, with a 7 French lumen that is separate to allow for aspiration. And when we look at the data, this was a very nice study out of India. It was a randomized prospective study that looked at a large cohort of patients that either went conventional ureteroscopy or with the fans. And what they found, not surprisingly, was significantly higher stone-free rates, particularly on the early post-ops, early CT imaging, with very low complication rates between the 2 groups, and lower intrarenal pressure, which is obviously a concern these days with irrigation in small systems. I think one important part of this is that when we talk about fans and all of the improvements that it may offer, is it's not something that's super easy, and there are some subtle hints. The University of Michigan team in their video presentation did offer some different highlights in terms of accurate sizing of the sheath, positioning the sheath when you are lasering to optimize aspiration of the stones, and then how to manipulate this when you don't have an assistant to hold the sheath in, so doing it individually, as well as sort of key points on how to sort of optimize the suction. Conversely, the Northwell Lenox Hill group did present their very large series looking at the CVAC 2.0 system. Similarly, 114 patients requiring a sheath, and similarly, they saw very, very good stone-free rates compared to what we had seen traditionally reported for conventional ureteroscopy with low complication rates. I think one thing that they also nicely pointed out in this presentation is that there is a learning curve to CVAC as well. So you sort of have some cases that go really, really well, but you do need to do a certain number of cases to become efficient with this. There is some concern with plugging or clogging of the system, and are you able to get this? Sometimes you have to use this over a sheath, a larger sheath, a 12-14 sheath, and are you able to do this routinely in non-pre-stented patients? So I think there is a learning curve. The team out of Mayo did look at this head-to-head. It was a prospective, not randomized, so observational study between fans and CVAC 2.0. Of note, you will see that they had very different stone sizes, so they weren't completely paired together, but what they found was overall comparable stone-free rates, but the amount of stone that was removed with CVAC wasn't actually dependent on as much how big the stones were. So there may be some thoughts that CVAC using a 7 French lumen is able to remove maybe more stones, but obviously for fans it depends on what stones, what ureteroscope you use and what size sheath you use. And then these aren't the only players in town. We also now have DIS, which is the direct in-scope suctioning channel. So traditionally, some people may have put a syringe on their traditional ureteroscope to aspirate, but there are new scopes out that will have this sort of built in to help you toggle the scope a little easier to aspirate. And in this study from Loma Linda, they looked at the newer scopes with smaller sizes, both a 9.2 and a 7.5 French ureteroscope, using the DIS, and what they found was it did remove larger stone or more stones than conventional aspiration, but it definitely needed the larger lumen. You needed the 5-point French lumen for the 9.2 scope French to remove larger stones, and it did depend on where you were. If you had to deflect in the inner polar or lower pole, you weren't able to aspirate as much. So definitely newer technology, not as much out yet, but we'll see where it goes. So Dr. Nakada, as we start our discussion, there's a lot of presentations this week on vacuum aspiration. Should we be putting this as part of our standard of care with retrorenal surgery? And if you do this, which device or how do you choose, and which patients do you choose this for?
Yeah, thanks, Davis. The service of the presidency lasts till the end of the meeting, no doubt about that, but delighted that you're all here. And we have a chance to go over what's new in stones. And I think this year there's a lot. I'm always cautious to say anything is the standard of care, but I do think vacuum aspiration, represents a substantive change in how we treat patients. And in particular, to me, the simplest metric is that there will be some cases that we'll be able to do retrograde using vacuum aspiration that we, may not have been able to do in the past. So perhaps at some level, PCNL utilization will go down and these vacuum cases will increase. My initial feeling is maybe once you get above 6 or 7 millimeters, you can begin to really see a benefit in using vacuum aspiration. So that's where I would start. With regards to the second question, which I think is a very good one, it is difficult to pick a device. And, I think we're in a world where you can't have always all the devices in front of you, to tailor, the device to the case. So I think my approach is we try to identify what we think is best for our system. And I think as surgeons, the best thing we can do is be comfortable with one device. So I think you're much better off using one of these devices and understanding it and utilizing it safely and be able to explain your results to your patients. I think that's sort of the way I would view this. But at this point, it's pretty exciting. I think it's been years since we've had a change of this nature.
Great. When we next move to what are some of the main takeaways that you should take home, ultimately, laser therapy is the fundamental part of what we do for stone treatments. It's how we fragment stones to ablate stones. We've known that there are several players that are out and some that have been newly introduced. So we have the holmium YAG, the thulium fiber, and now we have the pulse thulium YAG. The team out of France did look at this in vitro, and what they found was I don't think we still have the perfect laser currently. Definitely there are some lasers that ablate more optimally for different types of stones, and so we're still trying to transition to figure out what is the optimal setting and which laser may be better for what certain stones. The Wisconsin group talked in the plenary about a practice-changing paradigm shift of their multi-center randomized trial between high-powered holmium laser and thulium fiber as part of their multi-center group, and did see no difference in stone-free rates with very low complications and changes in quality of life, which does confirm what we have seen over the past, which is that both laser modalities are pretty efficacious for stone treatment. The team out of Chile showed in their randomized prospective trial looking at the pulsed pulse thulium laser with high-powered holmium, again, very comparable stone-free rates with low complications. And so I think the data is still saying that whatever you have is going to be very good. I think one of the concerns that was highlighted in many of the sessions is though we have to be very mindful of high-powered lasers and heat generation. The team out of UC Irvine noted in their in vitro studies that you do create a lot of heat, and particularly you can get over the threshold of the 44 centimeters Celsius is sort of the threshold. Thulium fiber does look like it generates higher temperatures, but at least in this study, they were able to maintain it low. The team out of Mount Sinai did a very nice clinical study with ECRS and noted that using either high-powered holmium or thulium fiber, if you're using low-power settings, if you're using fragmentation settings, you never reached over that 43 or 44 degree threshold in the kidney, in the collecting system, or within the parenchyma. But once you started to go to dusting or pot dusting settings, the very higher settings, that's when we were seeing these higher temperatures, both in the collecting system and within the parenchyma, and being very mindful, and thulium fiber was a little bit higher. I thought the Loma Linda team did a really nice presentation suggesting that, when we do these cases, you do occasionally get air bubbles. And some people do aspirate them. Some people just try to avoid it. And they showed nicely that if you go through an air bubble, either through the high-powered holmium or the thulium fiber, you can generate really significant high temperatures very, very quickly. They were able to, at 1 second through the bubble, they got temperatures over 60 degrees Celsius. At over 7 seconds, they got over 100 degrees Celsius. And so now you're getting protein degradation. So definitely something to keep in mind. What are sort of the consequences of having this high powered in heat? The team from Northwestern looked at a database, and they did see 2 times higher ureteral stricture rates using thulium fiber compared to high-powered holmium. Obviously the limitations here is we don't know what the settings were, we don't know the specifics with where the stones were, the degree of impaction, but this is something to be mindful of. And the team from Alberta, Canada noted that if you looked at patients who had lasers, in this setting thulium fiber, and they had pre and post-op creatinines and renal function over time, they did see that patients who had worse renal function over time had higher laser energy and time used. And so this is something that we very need to be mindful of. I think one thing to be mindful of is as we're getting new modifications, the team out of Russia, as well as in France, showed both clinically and in vitro studies that there are new modifications. This is to the thulium fiber laser with a stone sense mechanisms, which helps sense when you're on the stone and when you're on tissue. And so it does avoid potential injuries. And the team out of Loma Linda showed that there are some modifications that are coming out with existing thulium fiber lasers, such as the dual cycle modifications that results in less heat. So Dr. Nakada, how do you choose which laser to use in which stone settings, and are there particular steps that we should be using for safety?
Yeah, so that's a great review, Dr. Viprakasit. First, I would acknowledge, the outstanding work of my partners, Dr. Knadler, Antar, and Sorrell, in the randomized trial. And I think this is another area, lasers, in particular for stones, where we're just, we have a wealth of riches here. And I think the question is, I think at the end of the day, we know the iterative differences between, now thulium fiber, holmium with Moses, and the Thulio, and others. But maybe what's more important is what else you do, in your operating room with a laser. And if you're doing, laser prostatectomy, you're doing a lot of stricture work, I think it's reasonable to incorporate that as part of your selection process in terms of what you have in your operating room. And I would just recommend that we know that most of these lasers work very well, particularly for stone disease, and I think you get comfortable, again, with one system or a system you understand and you can manage. Obviously, there's some unique stuff out there with Stone Sense, and that's great, but if we can get it, great, but if not, it's in the distance. To answer your question regarding steps for laser safety, I mean, certainly this is critical. There have been a number of good studies at this meeting that talk about surgeon safety in terms of ergonomics, even preserving of hearing, and I think we as physicians have to take care of ourselves. So we take laser safety very seriously. We follow the rules. People have eyewear, and you really have to be careful when exchanging laser fibers not to miss a damaged fiber and risk something. So I would just say safety first.
As an endourologist, one of the nice things I like is we get a lot of new tools and a lot of new technology to play with. And so when we think about what's game changing, we've talked about, better lasers, we've talked about aspiration. I think what might also change our field is continued new technology with our scopes. We're going to smaller and smaller scopes now, particularly in the disposable field. The Loma Linda team looked at their in vitro comparison of the new 6.3 French scope, which has a 3.6 inner diameter, and so smaller, maybe better. They noted, very good optical resolution, very good deflection, and there was slightly lower irrigation rate, even though it's quoted as the same size lumen as some of the other scopes. But maybe you don't really, it's not that much different, and maybe you don't need that much more irrigation when you have such a smaller scope. And the team out of Oxford also noted that, particularly if we're thinking about fans and we're thinking about aspiration, if you have a smaller scope for the given size sheath, you can obviously irrigate and aspirate bigger size fragments. And when they noted here, even with the 6.3 French sheath, that they were able to get, very large fragments that they weren't able to get out with the other larger scopes. And so I definitely think this is something that may help, particularly when we're thinking about stentless procedures and trying to, these no-touch approaches, smaller scopes may be useful. The team out of Vanderbilt said, well, if you can laser the stones smaller and you can aspirate them smaller, make sure you can get to them. And so they showed their initial clinical trial on the ideal basket, the endothelial basket, which is a flexible basket that you can manipulate independent of the handle, and it bends in sort of the 90 degrees, so that maybe you can find some of the stones that you're not able to get to before, and then subsequently basket and relocate it. And then there's a new thoughts on maybe treatment of asymptomatic stones. The team out of University of Washington has been working on this for a bit, but published their clinical work looking at both burst wave lithotripsy as well as ultrasonic propulsion. And in their small cohort of patients, they were able to successfully move and treat, patients with asymptomatic, relatively small stones pretty successfully without very much complication. So Dr. Nakada, how do you incorporate these new technologies into your OR, and do you think we'll soon start no longer observing some of these smaller asymptomatic stones?
Yeah, thanks, Davis. So first, with regards to incorporating new technology, my answer is very carefully. I think when we're approached about looking at new technology, in the operating room, my first question is really, how does this help my patients, and how does it improve the quality of care that we provide? And I think if the answers are correct, we'll move ahead, but with care to be very transparent about what it is we're using and why we're using it. So I'd urge you all to think of it that way. With regards to observing small asymptomatic stones, this is fantastic technology. We've known about it for some time. At least in the United States, we're having trouble, treating patients with symptomatic stones in a reasonable time. So I think we'll be challenged to begin to manage a completely new population, if you will, assuming you're not treating asymptomatic stones now. I also struggle a little bit with which patients you would want to treat and which you wouldn't. But certainly it's early days, but it's technology that very well could have a big place.
And finally, to think about some things that were surprising in terms of medication therapy, I like this study from the University of Florida, which was a randomized trial looking at phenterlamine and topiramate, which is a combination medicines for weight loss to help with treatment of uric acid stone formers. So these were obese, pre-diabetic or diabetic patients with predominant uric acid stones, and they randomized them into either this drug regimen versus standard alkalinization medicine. And what they found was significantly higher urine pHs, significantly lower supersaturation uric acid levels, and lower stone volume over time. And so I do think this is a medicine that I routinely counsel, like topiramate, at least for calcium phosphate stone formers, try to talk people out of taking. And so it was a little surprising to think of it as a potential treatment or therapeutic. And so I like that. I think the other part that I found fascinating was there was a plenary discussion on genetics and stones. And I do think this is something that we need to be talking about more. The UAB team looked at a very large series of almost 300 patients that are high risk, and they found the 40% positive variants, and about a third of those were some known variants. And in the patients that had known variants, these were higher risk patients. They had worse stone disease, they had worsening renal function, they required more interventions, and they were even able to diagnose a subset of those with new, very rare genetic conditions, which was nice. The team out of Iowa, to conclude, specifically looked at brushite stone formers, which we always think of as being maybe more aggressive or more serious patients. And then in half of those patients, or I'm sorry, 80% of those patients, they actually found a variant, and one of the variants that was the predominant one may be associated with phosphate issues that may lead to better therapeutics or potentially other targets for prevention. So Dr. Nakada, to conclude, how do you envision the use of genetic testing in stone disease now and in the future?
Yeah, I think this is the future, and to some degree, the future is now. This is where we would love to be, I think, and opportunities day by day are more and more abound, and certainly the focus on the patients with the worst stone disease will be a tremendous clinical opportunity. The question just will be how quickly can we get this technology to the public?
Great. And so for take-home messages, vacuum aspiration is definitely something that is very exciting, and many people will begin to use. Different laser modalities are here, but we do be mindful of complications such as heat generation. There are smaller scopes and new disposables at our disposal, literally, that will help us improve our efficient treatment to patients. Perhaps one day we may also start to treat some of these asymptomatic stones in the clinic, and the role of genetic testing is pretty exciting as it continues to evolve. Thank you very much.